Hello, everyone. So we will start with chapter 9, where we left off. Autosomal recessive inheritance. An affected individual is homozygous for the muted allele in the gene. Sometimes there is a different mutation on each copy of the gene. For example, cystic fibrosis, and an affected individual is a compound heterozygote. In either situation, they will have inherited an abnormal allele from each parent, both of whom will usually be unaffected heterozygous carriers. For a couple with both parents being carriers, the risk of any child being affected, male or female, is 1 in 4, 25%. That was shown in the figure. All offspring of an affected individual will carry the condition. If an affected individual has children with an unaffected carrier, then each has 50% chance of being affected. Consanguinity, it is thought that we all carry 6 to 8 abnormal recessive genes. Fortunately, our partners usually carry different ones. Marrying a cousin or another relative increases the chance of both partners carrying the same autosomal recessive gene mutation. Cousins who marry have a modest increase in the risk of having a child with a serious recessive disorder. Raising this for discussion with families is often a very delicate matter, as it may trigger feelings of guilt, blame, and intercultural disrespect. The frequencies of disease alleles at recessive gene loci vary between population groups. When the gene occurs sufficiently often and the gene or its effect can be detected, population-based career screening can be performed and antenatal diagnosis can be offered for high-risk pregnancies where both parents are carriers. Disorders that have been screened for in this way for many years include sickle cell disease in Black, African, and African Americans, the thalassemias in those from Mediterranean or Asian populations, and Tay-Sachs disease in Ashkenazi Jews. With development in DNA sequencing technologies, it is becoming possible for the range of disorders being screened increase dramatically. Wealthy countries, sorry, wealthy countries that practice customary consanguineous marriage are beginning to use these technologies to identify the genetic basis of the recessive disorder prevalent in their communities and to screen for a broad range of conditions. So we'll discuss the table of autosomal recessive inheritance, examples of autosomal recessive disorders, congenital adrenal hyperplasia, cystic fibrosis, Friedreich ataxia, galactosemia, glycogen storage diseases, Hurst syndrome, oculocutaneous albinism, phenylketonuria, sickle cell disease, Tay-Sachs disease, thalassemia, and Werdnig-Hoffmann disease, SMA1. The figure shows autosomal recessive inheritance in both parents are carriers and the offspring have 25% chance of being affected, 25 unaffected carriers, and 25% are normal. Now the pedigree to show autosomal recessive inheritance. And then the summary, autosomal recessive inheritance affected. Individuals are usually homozygous for the abnormal gene. Each unaffected parent will be a heterozygous carrier. Two carrier parents have a 1 in 4 risk of having an affected child. Risk of these disorders varies between population as increasing and is increased by consanguinity. Autosomal recessive disorders often affect metabolic pathways, whereas autosomal dominant disorders often affect structural proteins. Now, the X-linked inheritance, X-linked conditions are caused by alterations in gene found on the X chromosome. These may be inherited as X-linked recessive or X-linked dominant traits, but the distinction between these is much less clear than in autosomal traits because of the variable pattern of X chromosome inactivation in females. In X-linked recessive inheritance, as shown in the box, male are affected, female carriers are usually healthy, Occasionally, a female carrier shows features of the disease. Each son of a female carrier has a 1 in 50% risk of being affected. Each daughter of a female carrier has a 1 in 50% risk of being a carrier. Daughters of affected males will all be carriers. Sons of affected males will not be affected because a man passes a Y chromosome to his sons. The family history may be negative because new mutations and gonadal mosaicism are fairly common in some conditions. Identification of carrier females in a female requires interpretation of the pedigree. This search for mild clinical manifestation and the identification of carriers through specific biochemical or molecular tests. Identifying carriers is important because a female carrier has 50% risk of having an affected son, regardless of who her parent is, partner is, and X-linked recessive disorders can be very severe. X-linked dominant disorders where both males and females are affected are unusual. An example is hypophosphatemic rickets, which is vitamin D resistant rickets. In some other X-linked dominant disorders, a female carrying the mutation will be affected, while the mutation carrying males have an even more serious condition. Thus, a mutation that causes Rett syndrome, a neurodegenerative disorder in a girl, will cause a lethal neonatal onset encephalopathy in males. Another reason why sex-linked condition may predominantly affect females is because it usually arises through mutations at spermatogenesis, for example, Rett syndrome. As male offspring must inherit a Y chromosome from their father, they will not inherit any mutation in the X chromosome that arise during spermatogenesis. So we will see the examples of X-linked inheritance. Examples of X-linked recessive is color blindness, Duchenne's and Becker muscular dystrophies, Fragile X syndrome, G6PD deficiency, hemophilia A and B, and Hunter syndrome, mucopolysaccharidosis 2. Now the X-linked recessive inheritance, where there is a carrier female and a normal male, offsprings will be carrier female, affected male, and 25% normal. Typical pedigree of X-linked recessive inheritance, showing Queen Victoria carrier for hemophilia A, and her family chose affected males in several generations related through females, and that affected males do not have affected sons, contrast with autosomal dominant inheritance. Now, the summary, X-linked recessive inheritance, males are affected, females can be carriers, but are usually healthy or have mild disease. Family history may be negative, many arise from new mutations or gonadal mosaicism. Identifying female carriers is important to be able to provide genetic counseling. All the female offsprings of affected males will be carriers, but none of the male offspring can inherit the mutation. Half of the male offspring of a female carrier will be affected, and half of the female offspring will be carriers. Y-linked inheritance, Y-linked traits are extremely rare. Y-linked inheritance would result in only male being affected, with transmission from affected father to all his sons. Y-linked genes determine sexual differentiation, spermatogenesis, and mutations are associated with the infertility and so are really transmitted. Now, unusual genetic mechanisms, trinucleotide repeat expansion mutation. This is a class of unstable mutation that consists of expansions of trinucleotide repeat sequence inherited in Mendelian fashion. Fragile X syndrome, myotonic dystrophy, and Huntington disease are among the best known of these disorders. They follow different patterns of inheritance, but share certain unusual properties due to the nature of the underlying mutation. Trinucleotide repeat disorders exhibit a phenomenon known as anticipation. The triplet repeat mutation is unstable and can expand between subsequent generations. In general, a larger expansion causes a more severe form of disease. This means that these conditions can become more severe in successive generations of the family. There are two major categories of triple repeat disorders depending on whether or not the triplet repeat is in the coding sequence of the gene. When the triplet repeat expansion When the triplet repeat expression is in the coding sequence, as in Huntington's disease and in a number of other neurodegenerative disorders, proteins containing an excess of the amino acid glutamine are produced. Glutamine can damage the cells in the central nervous system when present in its excess, leading to neurodegeneration. When the triple repeat expansion is in other regions of the gene, reduced quantities of protein are produced. In these cases, the reduction in the amount of the available proteins lead to symptoms of the condition. One such example is myotonic dystrophy, which is described further in neurological disorders. Most of the triple repeat disorders are autosomal dominant, but there is one autosomal recessive disorder, Friedreich ataxia and Fragile X syndrome, which is X-linked. Fragile X syndrome, the prevalence of significant learning difficulties in males due to Fragile X syndrome is about 1 in 4,000. This condition was initially diagnosed on the basis of cytogenetic appearance of an apparent break, a fragile site in the distal part of the long arm of the X chromosome. Diagnosis is now achieved by molecular analysis of the trinucleotide repeat expansion in the relevant gene. Although it is inherited as an X-linked disorder, some 40 to 50% of female carriers having learning difficulties, usually mild to moderate, more puzzling is the observation that males can be unaffected but transmit the condition through their daughters to their grandsons. This is not possible in hemophilia or Becker muscular dystrophy, for example, where a male cannot inherit the condition from his family and transmit the condition for his children without himself being affected. This can occur in Fragile X because the triplet repeat expansion varies in its nature with its size. The normal range of repeat numbers is up to about 45 repeats. When larger than that, the block of repeats become increasingly unstable but continues to permit Fragile X gene expression until a full mutation is reached at about 200 repeats. For 55 repeats to 200 repeats is known as the pre-mutation range, and a male can inherit the pre-mutation transmitted to his daughters, who will all be carriers while being intellectually normal and without the physical features of Fragile X. Because these full mutations always arise from expansion of pre-mutations and never directly from normal genes, the mothers of the affected males have to be carriers of the pre-mutation or full mutation. Offering referral for genetic counseling is therefore appropriate for all Fragile X families, especially as there can be associated disorders from pre-mutation carriers in adult life. Now, the bullet point, Fragile X syndrome is the second most common genetic cause of severe learning difficulties after Down syndrome. Mitochondrial or cytoplasmic inheritance. Mitochondria as cytoplasmic organelles that function as a cellular compartment within which many different metabolic pathways are located, including most prominently the production of energy by oxidative phosphorylation. They contain their own DNA, mtDNA, but most of the proteins involved in mitochondrial metabolic reactions are encoded in the nuclear genome. The mtDNA encodes proteins involved in oxidative phosphorylation together with the RNA and protein necessary for mitochondrial protein synthesis. This is a Fragile X syndrome child with Fragile X syndrome. At this stage, the main physical feature is often the prominent eyes. Clinical finding in males with Fragile X syndrome, moderate severe learning difficulty, IQ 20 to 80, mean is 50, macrocephaly, macroorchidism, postpubertal, characteristic facies, long face, large awaited ears, prominent mandible and broad forehead, most evident in affected adults. Other features, mitral valve prolapse, joint laxity, scoliosis, autism, hyperactivity. Each cell contains thousands of copies of the mitochondrial genome. Inherited disorder of mitochondrial function may result from mutations in the nuclear genome or less, often from mutations in mitochondrial genome, mtDNA. In disorders of the mtDNA, the mutation may be present in all or only some of the mitochondria, so that the tissue affected and the severity of the condition can be highly variable. Mutations in mtDNA cause overlapping clusters of disease phenotypes, with high energy tissues such as muscle, brain, and heart, and the retina being more commonly affected. For example, Leber hereditary optic neuropathy and various mitochondrial myopathies, and then encephalopathies such as MERFF, MELAS, and NARP. These conditions are described in more detail in inborn errors of metabolism. Disease caused by mutation in mtDNA show only maternal transmission because only the egg contributes mitochondria to the zygote. Imprinting and uniparental disomy. In the past, we assumed that the activity of a gene is the same regardless of whether it is inherited from the mother or father. It has been shown that the expression of some genes is influenced by the sex of the parent who transmitted. The phenomenon is called imprinting. If one copy of the gene is said to be imprinted, that copy is switched off in at least some tissues. An example involves Prader-Willi syndrome, hypertonia, developmental delay, hyperphagia, and obesity. The PWS chromosomal region is found at 15q11 to 13, that is at bands 11 to 13 on the long arm of chromosomal 15. Both the paternal and maternal copies of the chromosomal region have to function for normal development. In the absence of a functioning paternal copy of the region, a child will develop PWS, as some genes are maternally imprinted. By contrast, the female to inherit a functioning maternal copy of this chromosomal region results in an entirely different condition, Angelman syndrome, leading to severe cognitive impairment, a characteristic facial appearance, ataxia, and epilepsy because of a lack of expression of UBE3A gene and the paternal copy being imprinted. There are two main ways that a child can develop one or other condition: deletion de novo, as per in the figure later. Paternal chromosomes are normal and a deletion occurs as a new mutation in the child. If the deletion occurs on the paternal chromosome 15, the child has Prader-Willi. If the deletion affects the maternal chromosome 15, the child has Angelman syndrome. Uniparental disomy. This is when a child inherits two copies of chromosome from one parent and none from the other parent. In Prader-Willi, the affected child has no paternal but two maternal copies of chromosome 15q11 to 13. In Angelman syndrome, the affected child has no maternal but two paternal copies of chromosome 15q11. This can be detected with DNA analysis. There exist other less common mechanisms that can lead to these conditions. Now, the bullet point imprinting is the unusual property of some genes that express only the copy derived from the parent of the given sex. Now, the imprinting from a deletion and imprinting from a uniparental disomy, genetic disorder resulting from deletion of an imprinted gene. If the deletion occurs on chromosome 15, inherited from the father, the child has Prader-Willi syndrome. The deletion occurs at chromosome 15 from the mother. The child has Angelman syndrome. Genetic disorder resulting from uniparental disomy affected imprinted chromosome region. Child who inherits two maternal Chromosome 15S will have Prader-Willi, and a child who has two paternal chromosome 15S will have Angelman syndrome. Now, polygenic, multifactorial, or complex inheritance. There is a spectrum in the etiology of the disease from environmental factors, for example, trauma at one end, to purely genetic causes, Mendelian disorder at the other. Between these two extremes are many disorders that result from the interacting effects of several genes. Hence, the term polygenic, with or without the influence of environmental or other unknown factors, including chance. Multifactorial or complex, these terms are used interchangeably. Variance in quantitative traits such as height, intelligence, result from complex interaction between environmental factors and multiple genetic influence. Environmental factors include early life, including intrauterine experiences. These parameters are thought to show a Gaussian normal distribution in the population. Similarly, liability of an individual to develop a disease of multifactorial or polygenic etiology has a Gaussian distribution. The condition occurs when a certain threshold level of liability is exceeded. Relatives of an affected person show an increased liability due to inheritance of genes conferring susceptibility, and so a greater proportion of them than in the general population will fall beyond the threshold and will manifest the disorder. The risk of recurrence of polygenic disorder in a family is usually low and is most significant for first-degree relatives. Empirical recurrence risk data are used for genetic counseling. They are derived from family studies that have reported the frequencies at which various family members are affected. Factors that increase the risk to relatives are having a more severe form of the disorder. For example, the risk of recurrence to siblings is greater in bilateral cleft lip and palate than in unilateral cleft lip alone. Close relationship with affected person, for example, overall risk to siblings or children is greater than to more distant relative. Multiple affected members, family members, for example, the more siblings already affected, the greater the risk to recurrence. Sex difference in prevalence, with the recurrence risk greater in the more commonly affected sex, and if the affected individual is of the less commonly affected sex. The phenotype clinical picture of a disorder may have a heterogeneous mixed basis in different families. For example, hyperlipidemia leading to atherosclerosis and coronary heart disease can be due to a single gene disorder, such as autosomal dominant familial hypercholesterolemia, but some forms of hyperlipidemia are polygenic and result from an interaction of the effect of several genes and dietary factors on various lipoproteins. In some complex disorders, such as Hirschsprung disease, the molecular genetic basis and the important contribution of new mutation are becoming clear in many multifactorial disorders. However, the environmental factors remain obscure. Clear exceptions include dietary fat intake and smoking in atherosclerosis, and viral infection in insulin-dependent diabetes mellitus. For neurotube defects, the risk of recurrence to siblings is lowered from about 4% to 1% or less in future pregnancies if the mother takes folic acid before conception and in the early weeks of pregnancy. So the multifactorial polygenic complex is a diagram showing the increased liability of multifactorial disorder in relatives to infected individual. Conditions often associated with multifactorial polygenic complex inheritance: congenital malformations, neural tube repair, anencephaly and spina bifida, congenital heart disease, cleft lip and palate, pyloric stenosis, developmental dysplasia of the hip, talipes equinovarus, hypospadias, childhood atopy, especially asthma and eczema, epilepsy, diabetes mellitus type 1, insulin-dependent diabetes, adult type atherosclerosis and coronary artery disease, diabetes mellitus type 2, Alzheimer's disease, malignancy, especially the common cancer, for example, breast and colorectal cancer, hypertension, cerebrovascular disease, especially stroke. Now, the dysmorphology. The term dysmorphology literally means the study of abnormal form. It refers to the assessment of birth defects and unusual physical features that have their origin during embryogenesis. Pathogenic mechanism: malformation, primary structural defect occurring during the development of a tissue or organ, for example, spina bifida, cleft lip, and palate. Deformation implies an abnormal intrauterine mechanical force that distorts a normally formed structure, for example, joint contractures or pulmonary hyperplasia due to fetal compression caused by severe oligohydramnios. Disruption involved destruction of a fetal part that initially formed normally. For example, amniotic membrane rupture may lead to amniotic bands that may cause limb reduction defects. Drugs such as phenytoin, warfarin, or thalidomide can cause teratogenic effect. Viruses such as rubella or cytomegalovirus may damage the normally formed embryo fetus. Dysplasia refers to abnormal cellular organization or function of specific tissue types, for example, skeletal dysplasias, dysplastic kidney disease. Clinical classification of birth defects, single system defect. These include single congenital malformations such as spina bifida, which are often multifactorial in nature with fairly low recurrence risk. Sequence refers to a pattern of multiple abnormalities occurring after one initiating defect. Potter sequence. Potter syndrome, fetal compression and pulmonary hypoplasia is an example of a sequence in which all abnormalities may be traced to one original malformation, causing failure of fetal urine, excretion from renal agenesis, or posterior urethral valves. These are syndrome recognized by Gestalt clinical recognition. Noonan syndrome affects both male and female. There are some similarities with phenotype and Turner, but it's caused by a mutation of a normal and autosomal dominant gene, and the character is normal. The figure is Williams syndrome is usually sporadic. The 9.19 is Prader-Willi. Now, the clinical features. First, the clinical features of Noonan is characteristic facies, occasional mild learning difficulty, short web neck with trident hairline, pectus excavatum, short stature, congenital heart disease, especially pulmonary stenosis, atrial septal defect. Clinical features of William are short stature, characteristic facies, transient neonatal hypercalcemia, congenital heart disease, supravalvular aortic stenosis, mild to moderate learning difficulties. This is Prader-Willi, characteristic facies, hypotonia, neonatal feeding difficulties, faltering growth in infancy, obesity in later childhood, hypogonadism, developmental delay, learning difficulties. Now, the association, a group of malformations that occur together more often than expected by chance, but in different combinations from case to case. For example, vertebral anomalies, anal atresia, cardiac defects, tracheoesophageal fistula, renal anomalies, limb defect, rectal association syndrome, when a particular set of multiple anomalies occurs repeatedly in a consistent pattern, there is known or thought to be a common underlying causal mechanism. This is called a syndrome. Multiple malformation syndromes are often associated with moderate or severe cognitive impairment and may be due to chromosomal defects, a single gene defect, dominant recessive or sex-linked. Exposure to teratogens such as alcohol, drugs, especially anticonvulsants such as valproate, carbamazepine, and phenytoin, or viral infections during pregnancy, unknown cause, syndrome diagnosis. Although most syndromes are individually rare, recognition of a dysmorphic syndrome is worthwhile as it may give information regarding risk of recurrence, prognosis, likely complications, which can be sought and perhaps treated successfully if detected early, the avoidance of unnecessary investigation, experience and information which parents can share with other affected families through family support groups. Examples of syndromes recognized by facial appearance are shown. The importance and impact of syndrome diagnosis demonstrated in case history. Databases are available to assist the recognition of thousands of multiple congenital anomaly syndromes, for example, London Dysmorphological Database and Pocket Similarity. So this is a summary. Dysmorphology comprise birth defect and abnormal clinical features originating during embryogenesis, maybe malformation, deformation, disruption of dysplasia, may be classified as single system defect, sequence associational syndrome. Syndromes are recognized as gestalt, which may be aided by dysmorphic database. Gene-based therapy, the treatment of most genetic disorders is based on conventional therapeutic approaches. Gene therapy involves the repair, suppression, or artificial introduction of gene into genetically abnormal cells with the aim of curing the disease and is at an experimental stage for most genetic conditions being studied. There are still many technical and safety issues to be resolved. Gene therapy has been initiated in adenosine deaminase deficiency, a rare recessive immune disorder, ADA deficiency, malignant melanoma, and cystic fibrosis, and some clinical benefit has been reported in a few patients. At present, it is generally accepted that gene therapy should be limited to somatic, not germline cells, so that the risk of adversely affecting future generations is minimized. However, other treatments based on a genetic understanding of disease are being introduced into practice. Current areas of research include Duchenne muscular dystrophy, cystic fibrosis, and retinitis pigmentosa. An increasing understanding at the molecular mechanism underlying the pathophysiology of many genetic conditions has also led to new targeted drug treatments in several conditions, including enzyme-resistant therapy for certain inborn errors in metabolism, mTOR inhibitor therapy in tuberous sclerosis. Now we will discuss the case presentation, syndrome diagnosis, genetic counseling. Sean, the second child of healthy parents, was born at term by emergency C-section for fetal distress. The pregnancy has been uneventful and no abnormalities were detected on antenatal ultrasound scan. He developed respiratory distress and investigation triggered by a cardiac murmur revealed and interrupted aortic arch and ventricular septal defect that requires surgical correction in the neonatal period. The parent asked about recurrence risk for congenital heart disease, referred to the genetic clinic. At that time, Sean was thriving and early developmental progress appeared normal. On examination, there were minor dysmorphic features, including the short philtrum, thin upper lip, and prominent ears. There was no family history of congenital heart disease, other significant problems, and no abnormalities were detected on examination of the parents because of an association between outflow tract abnormalities of the heart and deletion of chromosome 22. Cytogenetic analysis was performed using FISH, a submicroscopic deletion of the long arm of one chromosome 22, band 22q11 was detected. Other features of DiGeorge syndrome, hypocalcemia and T-cell deficiency, which occurs with the same chromosome deletion, were excluded, but could have been important in Sean's medical management. Parental chromosome analysis showed no deletion of chromosome 22q11 in either parent, including a low recurrence risk for future pregnancies because gonadal mosaicism for this deletion is very rare. The oldest sibling was also normal on testing because the parents had normal karyotypes. Their own brothers and sisters were not required to be tested. Identification of a 22q11 deletion indicated the other associated problem were likely. Subsequently, Sean required assessment by multidisciplinary child development team for development delay, which led to the former assessment of his educational needs and recommendation for placement in an appropriate school for children with learning difficulties, input from a clinical psychologist when behavioral problems appeared, ritualistic behavior, and obsessional tendencies. Input from speech therapy and plastic therapy, indistinct speech due to velopharyngeal incompetence and audiology review, conductive hearing loss due to recurrent otitis media. The impact of diagnosis and its implications are considerable for the family, and the parents needed support from a variety of professionals while coming to terms with the various problems as they became a parent. Written information and details of the 22q11 support group were given to the parents. Medical care was coordinated by the pediatrician. There was additional worry for the family about a subsequent pregnancy. Fetal echo showed no evidence of congenital heart disease, and the offer of invasive tests for decided genetic analysis was declined because of the low chance of recurrence and risk of miscarriage from the test. The baby was born unaffected, with chromosome studies performed on a cord blood sample revealing no abnormality. Now, genetic services in the UK. All health regions have a clinical genetics center where specialist genetic services are provided by consultants and other medical staff, genetic counselors, and laboratory scientists. Specialist clinical genetic assessment and genetic counseling are provided at the center and in a network of clinics throughout the region. Genetic investigation can be accessed through these clinical services as well as directly through primary and secondary care. Increased recognition of the disorders antenatally has necessitated expansion of perinatal genetic services in addition to pediatric and adult services. Genetic investigation. For many years, genetic investigation relied on determining the karyotype of visualization of chromosome with light microscopy. This has been transformed by tremendous advances in molecular testing. DNA analysis using polymerase chain reaction allows a rapid analysis of small samples. Main impact for genetic counseling is confirmation of a clinical diagnosis of an increasing number of signal gene disorders, dissection of female carriers in X-linked disorders, for example, Duchenne and Becker muscular dystrophies, hemophilia A and B carrier detection, autosomal recessive disorders, for example, cystic fibrosis, pre-symptomatic diagnosis, autosomal dominant disorders, for example, Huntington disease, myotonic dystrophy, familial cancer syndromes, antenatal diagnosis of an increasing number of Mendelian conditions. These are accompanied by the following methods. Mutation analysis for an increasing number of Mendelian disorders. It is possible to directly detect the actual mutation causing the disease. This provides very accurate results for confirmation of diagnosis and pre-symptomatic or predictive testing. Identifying the mutation in an affected individual may be very time-consuming, but once this has been done, testing other relatives is usually fairly simple. Examples are deletion. Large deletion mutations of at least one exon are common in a variety of disorders, including Duchenne and Becker muscular dystrophy, alpha thalassemia, 21 hydroxylase deficiency, congenital adrenal hyperplasia. Point mutation and small deletions, these can be readily identified if the same mutation causes all cases of disorders, as in sickle cell disease for most disorders. However, there is a spectrum of mutations. About 78% of cystic fibrosis carriers in the UK possess the F588 mutation, but over 900 other mutations have been identified. Most laboratory tests for a certain number of the most common mutations in the population they serve. This means that patients must be informed of the small risk that a mutation will not be detected. Trinucleotide repeat expansion mutation. These can be readily identified because the mutation in a given disease is virtually always at the same site and can be amplified from the same oligo DNA primers used in the amplification by PCR. The only difference is the size of the repeat sequence, which can be determined from the size of a DNA fragment containing the repeat. Next generation sequencing. It is now possible to generate large volumes of DNA sequence data in a rapid and cost-effective fashion. These techniques of high throughput sequencing are used to enable gene panel testing when a specific set of genes is sequenced. For example, all the genes known to be relevant to a specific disease presentation, for example, retinal degeneration, cardiomyopathy, infantile onset epilepsy. Whole exon sequencing, the coding regions of the genome are sequenced to determine variants which are then analyzed to interpret the findings. Whole genome sequencing, the whole genome is sequenced, including non-coding regions. This is predominantly used as a research tool, but development in this field is rapid, and whole genome sequencing (WGS) has technical advantage over whole exome sequencing, so that the current use of whole exome sequencing is likely to be replaced by whole genome sequencing over the next few years. Recent studies have focused on implementation of the next generation sequencing into clinical practice, and the Deciphering Developmental Disorders study utilized exome sequencing in a large cohort of undiagnosed patients with developmental delay, the result of being used to database decipher of genotypes and related phenotypes. In the UK, the 100,000 Genome Project is utilizing WGS to study a wide range of clinical conditions in adults and children. Genetic counseling, the main aim of genetic counseling is supportive and educational. Genetic counseling aims to support and provide information for individual couples and families to understand the situation, to make their own decisions about managing the disease or risk of disease, including decisions about genetic testing, reproduction to adjust their situation of their being affected by and at a risk of the genetic condition. Primary goal of genetic counseling is to provide information to allow for greater autonomy and choice in reproductive decisions and other areas of personal life. Avoiding additional cases of genetic diseases in a family may be a consequence of genetic counseling, but is not the primary aim. The elements of genetic counseling include listening to the questions and concerns of the patient or family, establishing the correct diagnosis, a small detailed history examination, appropriate investigations that may include chromosomal DNA or other molecular genetic analysis, biochemical tests, X-rays, and clinical photographs. Despite extensive investigation, including searching databases, the diagnosis may remain unknown. For example, in children with learning disability and normal appearances or only mild and non-specific dysmorphic features. Risk estimation, this requires both diagnostic and pedigree information. Drawing a pedigree of 3 generations is an essential part of the clinical genetic assessment. The mode of inheritance may be apparent from the pedigree even when the precise diagnosis is not known. In some cases, it may not be possible to define a precise recurrence. Risk and uncertainty may remain. For example, conditions that only affect one member of the family and are known to follow autosomal dominant inheritance in some families and autosomal recessive inheritance in other genetic heterogeneity. Communication information must be presented in an understandable and biased way. Families often find written information helpful to refer back to, and diagrams are often used to explain patterns of inheritance. The impact of saying the recurrence risk is 5% or 1 in 20 may be different from saying the chance of an unaffected child is 95% or 19 out of 20, and so both should be presented. Discussing options for management and prevention. If there appears to be a risk of offspring, all reproductive options should be discussed. These include not having any more children, reducing intended family size, taking the risk and proceeding with pregnancy or having antenatal diagnosis, and selective termination of an effective freezer. For some couples, donor insemination or ovum donation may be appropriate, and for others, achieving a pregnancy through in vitro fertilization and pre-implantation genetic diagnosis may be possible. Putting parents in touch with appropriate resources of support, such as the charity Unique, which provides support for families affected by rare chromosomal imbalances. Counseling should be non-directive, but should also assist in the decisive decision-making process, as shown in the figure. Influences of decisions regarding options for genetic counseling, magnitude, risk, perceived severity of disorder, availability of treatment, person's experience of this disorder, family size, availability of a safe and reliable prenatal diagnostic test, parental, cultural, religious, or ethical values. Counseling should be non-directive, but should also assist in decision-making process. Information from lay support groups may also be present. Genetic counseling aims to allow parents greater autonomy and choice in reproductive decisions. Pre-symptomatic predictive testing, children may be referred because they are at increased risk of developing a genetic disorder in childhood or adult life if the condition is likely to manifest in childhood, for example, Duchenne muscular dystrophy, or if there are useful medical interventions available in childhood, for example, screening by colonoscopy for colorectal tumors in children at risk of familial adenomatous polyposis coli, and then genetic testing appropriate in childhood. If the child is at risk on the late onset and untreated disorder, for example, Huntington's, then there is a very strong case for deferring genetic testing until the child becomes an adult or at least sufficiently mature to be actively involved in seeking the test, can make the decision for himself or herself. The child is not at the risk of developing the condition, but may be carrier at risk of transmitting the disorder to their future children. Then there is also a good case for deferring testing until the young person can participate actively in the decision. There may be less at stake with these reproductive carrier tests than with predictive tests for untreatable disorders, but there are still good grounds for caution and for careful discussions before proceeding with such tests. These difficult issues are often best handled through process of genetic counseling, supporting open and sustained communication within the family, and especially between parents and children. Pre-symptomatic testing of disorders of manifest in adult life should not be performed until the individual can consent on their own behalf unless there is a clear clinical benefit from testing earlier. Now, there's a table showing genetic investigations, cytogenetic analysis, karyotype, chromosome stained and visualized in the microscope, detects alterations, chromosome number, structural rearrangement. This matter is being replaced with molecular methods such as comparative genomic hybridization. Molecular cytogenetic analysis, which is FISH, fluorescent label DNA probes to detect the present number of chromosome location of specific chromosomal sequencing. Useful for microdeletion syndromes. Microarray comparative genomic hybridization detects chromosome imbalances using 1,000 DNA probe to investigate a whole genome with much greater sensitivity than cytogenetic methods. PCR amplification of specific target site within the genome, which then presents the conventional Sanger sequencing of the amplified data. And now we discuss next generation sequencing, rapid sequencing the whole genome or selected loci of the within the genome, and linkage disequilibrium in genome-wide association studies comparing the frequency of combination of alleles at nearby loci in a given population to identify genetic variants associated with specific diseases through a common ancestral origin. So this is the end of chapter 9. Yes. Thank you very much.